crosswise. Lower abdomen lengthwise, but upper abdomen crosswise. So in clinic, this is something that is a lot more common. When you do go crosswise, notice that you actually do have light on your IR now. Do you see that? So if you wanted to put your marker, now you can put your marker completely out of anatomy. Do you see that? Oh. You've got the light next to the patient. Cindy, go ahead and lift up your left arm just so that you can see. Right, so you've got the light there, you can put the marker there so it's completely out of anatomy. Okay. Notice that on the high cross, right? We are actually slightly above, we're almost above the shield now. Right, so if we were high enough, you might be able to leave the shield on while still getting the high cross. Okay, but once again, it can be a bit risky, right? Having the shield there. So let's go ahead and take the shield off. Thank you. Right, so for abdominal exams, it's actually recommended that you do not shield, right? It's possible to shield. I'll show you different ways you can try and shield. But if your shielding causes you to cover up important anatomy, and then you need to repeat your exam, you have now just given more radiation than if you had just not shielded in the first place. Does that make sense? So in that case, shielding has actually increased dose to the patient rather than decreasing dose. So you can try and shield if you want, but if you suspect at all that your shield is going to cause you to repeat the exam, it's probably better not to shield. At least in the case of the abdomen and pelvis. All right,
Also,
great. So you can come back over.
on test out, Mr. Fung, do you just want us to know, like, hey, don't shield in these positions, or do you want to see us like attempting to shield? What are you looking for, or just do we just?
In this case, for the abdomen, I believe I told the morning group that I do not expect you to shield. Okay. Yeah. Right, if you really want to be fancy, you can try, but I don't expect you to shield.
Okay.
Now, final thing. What is the purpose of the upright abdomen?
Fluid.
Fluid. What do you mean by fluid?
Yeah, I think that's it.
So, I mean, is there a difference between doing an abdomen upright versus doing it supine?
Yes.
There is. Okay. What kind of differences would there be?
The way
So
the organs lay?
Yeah, the organs, and you want to move some of them out the way, like when you're leaning down, it moves them out the way when you're leaning down.
All right, great. So like the effect gravity has on the organs, right? If you're standing up, gravity pulls them straight down. If you're on your back, then gravity kind of pulls them out to the side. Very good. What else? So what else might be a reason that a doctor would order standing specifically?
Constipation.
What is that?
Constipation?
Not constipation.
Gas?
Yeah, the gas from.
Yes. All right. So, got my water bottle here, correct?
Mm-hmm.
Okay.
Everyone see the water?
Yeah.
Everyone see the empty part of the bottle?
Yeah.
All right. What do you see in between? So you've got water, right? Fluid. You've got air. What do you see right here?
Line.
Right. There's a line here, correct? This line is called the air fluid level. Right? So you have fluid, you have air, and then you have your air fluid level. Now, let's take this erect patient and lay them down on their side. And now imagine that we're doing it supine. So now you're looking down like this. Right, so come over here and just look straight down at this bottle. Do you still see that air fluid level?
No.
No, you don't, right? So the purpose of the erect upright abdomen, right? The purpose of the erect or the purpose of the upright abdomen is to demonstrate air fluid levels. That's one of the big reasons why we would do this. Okay? So we want to look for some stuff like free air. Is there air in the abdomen that does not belong there? Right? We could use that to find out as well. So, we are looking for air and fluid when we do the upright. Now, because we are humans, right? Because things take time inside the body. When you have a patient that's laying down, right? And then you stand them up for this X-ray. The air and the fluid do not settle immediately. It takes time for all the air to finish rising. It takes time for all the fluid to finish falling. So, when you do these upright abdomen X-rays, you should wait, or you should ensure that the patient has been erect for at least 5 minutes before performing the exam. Okay? So, for example, all of us, we've been standing or sitting here for over 5 minutes now, right? So, no problem if any of us came up here and was the patient for an upright abdomen. But if I have been laying on a stretcher in the waiting room and you brought me in the room and you wanted to do an upright abdomen on me, you do not want to stand me up and immediately try and shoot. You want to sit me up or stand me up, wait at least 5 minutes, preferably 20 minutes for best results, and then you shoot your X-ray.
So between 5 to 20 minutes.
Right, minimum 5 minutes, 20 would be the best. Right, so I think all of us have been standing for 20 minutes, so we should have some nice pictures. But if I had been sleeping when you came in and I just got up and you tried to position me, you're not going to see it as nice. You want to be able to wait that time. Now, is it realistic for you to be in an X-ray department, bring a patient in for an exam, and then hog the room for 20 minutes while you just sit there, just so that you can shoot an upright abdomen? No, right? Unless the department is dead and there's literally no patients, and you can afford to do something like that, yeah, probably not going to happen.
For inpatient, can you let the nurse know to sit them up prior to the exam?
We can try.
In the waiting area, there's usually a tech there, right?
Yeah, we can try. Yeah. So there are some things that we can try and do to help.
So if you don't do it, we don't follow the 5 minutes, do we get a write-up for that, like taking an X-ray?
I'm really got a write-up for that.
I mean, like.
Well, you can't prove that you didn't wait for 5 minutes, right? There's no timer. But your images will just not look as good. Now, can they prove why they don't look as good? No. They can't prove that you only waited 3 minutes and 3.5 minutes, right? But they'll look at the image and they say, all right, this just doesn't look like what I was expecting. This doesn't look as optimal as I was expecting. Right? But if you do want good pictures, you want to make sure that they've been upright for at least 5 minutes. Now remember, that 5 minutes can include your positioning time. Right? So you get them in the room, you sit them up, and then you start going over your aided stuff with the patient, right? You start doing your explanations, right? They're sitting up or standing up while they do their dressing. They come over here, they're still standing while you're positioning everything. That might take up your 5 minutes to where the air and fluid have settled in time for your X-ray. So there is that. Okay. So these upright exams are often not done by themselves. If you do an upright abdomen, it usually comes as part of an abdominal series. So either upright and supine, or chest X-ray, upright and supine. Okay, so if you had an abdominal series and you had the supine abdomen and the erect abdomen, which one would you do first?
Upright.
Upright. Why?
Because we don't want to wait another 5 minutes to.
Very good, right? You don't want to lay them down for the supine, then sit them up and wait 5 minutes just to do the upright. Do the upright first, and then go to the table. Very good. Great thinking. All right. Any questions about the upright abdomen? You're okay? Okay. So, in that case, we are going to move on over to the table here.
Oh, there you go. Okay.
Remember with these sheets, right? Only unfold them halfway, right? Don't unfold them fully.
Cindy? Oh, no.
Sorry,
No. I was going to tell you, just so you know, I was recording, but when I was kind of scratching my arm, the phone went down, so it just looked, I was at your back, but obviously it wasn't intentional. I was like, it just, yeah.
No worries.
Okay.
It's loose. So
Okay, cool.
Okay. So, while we are aimed at the wall bucky, how many locks are active?
2.
Great. Both the blue and the green are active, correct? When we go over to the table, how many locks need to be active?
1.
Only one. Very good. So when we are here at the table, only the blue lock needs to be on. The green lock does not matter here. So don't think that you need to lock the green in somewhere here on the table. You do not. Right, the green can stay off. Okay? So don't think that, oh, it locked here, I have to keep it here. Right? Don't think that, oh, it locked here, I have to keep it here, right? That is not true. This can go elsewhere. It does not have to stay here. All right. Okay, I'll go ahead and demonstrate this real quick. Okay, we're at the table, right? We need to change our detector. So I'm going to swap this over to our table. Okay, now if you look down here, we've got the table bucky. We've got the laser. So we can line the table bucky and the laser up together, right? So rather than locking, this is what needs to stay centered to each other. Does that make sense? So you don't need to lock as long as these two remain centered. Okay. And finally, what should our SID be? 40. All right, so who would like to be our next patient? All right, so Veronica, can you get on the table? Okay, please stop. I wasn't actually expecting you to get on the table. I was expecting you to say something.
I was just like kind of low.
Okay, table's
And
kind of
the
low.
table wasn't locked.
But what else is the issue?
The booking in the way, the table fixing.
Yes, you have a tube in the way of your patient. Great, you set up your room, but how's the patient supposed to get on?
Yeah, I was looking at it and I was like, I want to see
And then
this.
the table wasn't locked.
Oh.
And so I lost it.
So, is this something you want to do?
No.
No. So, how can you avoid this? All right. Can you get onto the table? Much easier, correct? The tube is not in the way. But notice what I did with the tube. How did I move my tube back here?
You just moved it.
Moved it using which button? The
blue.
gray?
The blue.
That's right, I used the blue. Why? Because if you take a look, when I bring it back on the blue and it locks in position, I am still centered. So I can get my room ready, then I just move my tube out of the way in a single direction, get my patient on, right, raise the bed, move the tube back, and it is going to be all lined up, ready for me to go. So I've set up as much as I could without being in the way of my patient. Make sense?
Mhm.
Right. In this case, I'm also going to move this up the way, since what is the first thing you should do when the patient gets on the table?
Lock it.
Okay, it should be locked before the patient
No.
gets on the table, as Veronica pointed out.
No.
But after the patient gets on, what should happen?
Bring it up to your to your comfort level.
Great, we are going to raise this table. Do not work with the table all the way down there. Make sure you raise this up. Okay, yes, the table will stop here. This is still too low for me. I'm going to keep raising it. Alright, yeah. See, now I can kind of grab this without needing to bend over. So I like this height. Take
Does
this.
that change your SID?
It does, yep. So I had to readjust my SID just now so that it is 40 again. Okay. So once we are here, there is something else we need to do. So after you raise the table up, and we're going to be doing our supine abdomen, right? So our patient supine. So they're in position. There is something very important we need to do. So, after you bring the table up, you need to stand here either at the foot of the bed or at the head of the bed. Okay, so, come over to the ends of the bed, please. Either one, doesn't matter. And I want you to look at this patient and tell me what you see.
She's not sent, she's
Oh.
crooked.
That's right, our patient is crooked. Our patient is not straight.
Hold on.
If you take the time to try and center your patient only at the very end to check and find your patient is crooked, guess what? You have wasted all your time. You need your patient straight before you can begin centering and positioning. So always come to the head or the foot of the table and make sure that your patient is straight. If you are using a cloth sheet to cover your bed, right? Some places will use paper, so you can't do this. But if you are using cloth, you can use this to help straighten the patient out, right? So just relax. I want you to just relax. I'm going to wiggle you around a bit, right? I'm just going to fold this up. I'm just going to kind of like wiggle the patient back and forth while I pull them to get them nice and straight. Okay? Take a pen, hold it straight up and down, make sure that MSP is nice and lined up. Okay? Does that make sense?
Yes.
The end goal is we want that patient straight, right? So shoulders, hips, right? All of that should be in a straight line. If you see the patient like this, excuse me one moment. Okay, try not to move. I'm just going to move you. Right? So shoulders and feet are lined up, right? But the hips are curved, right? She's curving almost like a C, right? So you do need to make sure to adjust it. So either you adjust it yourself or you tell the patient what to do. Move your hips over, move your shoulders over. Okay. So, Veronica, move your hips over slightly to your left. Good. Stop here. All right. Great job. Make sense? All right, great. Yeah. Come on over here. Okay. Notice that this entire time, how have I been moving my patient around?
Free for all. Yeah.
Right, I've been floating my table, right? Have I touched my tube ever since I got things lined up? Have I touched my bucky ever since I got things lined up? No, right? I've only been moving my table. So, these two, the tube and the bucky, have stayed lined up this entire time, right? It doesn't matter what I do with this table, the tube and the bucky stay aligned. So, once you get these two lined up, do not touch them ever again. Once you get these lined up, do not touch these ever again. You just leave them exactly where they are. Because if you touch them, you have ruined your alignment and you will need to start over. Okay? So, if I'm like this, I'm like, oh no, I'm centered too low, or I'm centered too high. I need to move my cross here. you are not going up here and grabbing the tube. You touch this tube, and you are no longer aligned. All you're going to do is float your table around. Does that make sense?
Yeah.
To make this picture even better, right? Yes, we're going to be awesome text, and we want good pictures. Veronica, bend your knees, please. Okay, support underneath the knees, slight bend of the knees, helps this straighten out the back, makes the abdomen look nicer. Okay, so AP supine, correct? Where do we center? Are we at the crest or are we 2 inches?
At the iliac crest.
Great, this is one of the ones where we go at the iliac crest. So, sorry, I should warn you first, right? So, okay, I'm going to be feeling for your crests. Remember, once again, if you feel here and you're like, oh, I feel something bony, that is not your crest. That's your as is. Right? You're going to cut, right? You're going to follow it all the way up here. The iliac crest is going to be here at the side, right there. Right? So you're going to find the very top of this curve, and this is going to be the iliac crest. All right. So let me know. Okay, so now I'm at the level of the iliac crest here. Okay, I felt my crest was right there, so I'm at the height of my crest. Now, I understand that on some patients it will be difficult to find the iliac crest. And I'm going to tell you, no matter how difficult the patient is, no matter how much soft tissue or fat or muscle the patient has here on the flanks, you should always try your best to dig in there and find that iliac crest. Because that is going to be the best way to get your positioning. Now, let's pretend that despite our best efforts, we could not find the iliac crest. Is there something else we can do to help get us in the right area? Is there anything else at above the same level as the iliac crest? So, find your crests. I just want you to move your hands back and forth at this height. Do you feel anything else in this region right up here that feels like it is at the same height as your iliac crest? Belly button. Okay, very good.
Yeah.
So, Veronica, could you point to your belly button? That's your belly button? All right. So, a little bit high, right? But that'll get you in the general region. Alright, now let's closer. Alright, but belly button is going to get you into the general region of the iliac crest. Right? So if you really can't find it, you can ask the patient to point at their belly button. Now, belly button is not foolproof, as you can see. There is going to be some variation. Oh, you can bring your finger down. Right? Especially if you have a large patient, right? That soft tissue tends to be able to float around. It tends to be able to move. So you can't always trust the belly button. So, is there anything else we can do in addition to iliac crest or belly button? Well, if you look down here, where is the bottom of the light located? What is right here? What is right here? At the bottom of the abdomen.
Pubic symphysis.
Great, the pubic symphysis is right here. And the pubic symphysis is a bony structure that is palpatable. Right? You can feel the bony pubic symphysis if you try. Now, should you attempt to palpate the pubic symphysis? No, very good, right? Just because you can doesn't mean you should. Okay, that's a lawsuit waiting to happen. So, instead of palpating for the pubic symphysis directly, is there anything else here at the level of the pubic symphysis that you could feel for instead.
Couldn't you use ACEs and just go like 2 inches above it?
Could you use ACEs and go 2 inches above it? That is a possibility. ACEs to iliac crest, right, is going to be about 2.5 inches. So yes, that's one way you could try and estimate.
Could they bend their leg and you would feel the
Oh.
the
there.
crease in
Oh.
you know, and then
Mm-mm,
try
I'm
to
feeling
move,
it.
cuff that or
I'm not going to say
I'm
you
feeling
can
here.
use the crease, but there's something in
Yeah.
the general area, something that was mentioned earlier.
What's in the aces?
What else is here at the level of the pubic symphysis? What is this right here on the side?
The greater trochanter.
The greater
Oh, she says, yeah.
trochanters, yes. So if you feel here on the side of your leg, right? Flash, 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 and then there's this bony structure right here before it turns into like flesh and then your hip, right? This thing right here, your greater trochanter, right? That's right. You wiggle this back and forth, you can feel that greater trochanter moving around. This
Oh,
is
okay.
at the same level as that pubic symphysis.
Yeah.
Right? It's at the same height. So if you can palpate for that greater trochanter, then you can kind of estimate the level of the pubic symphysis. So I'm going to feel the side of your legs. Flash, flash, flash. Okay. Feel something going here. Right. So this bony structure to me feels like greater trochanter. Right. So feels like my greater trochanter is right here. So, boom, right here at the bottom of the line, right where the pubic symphysis should be. Do you see how that works? So you can use crest, you can use greater trochanter. They can help you guide you to get to the correct location of your center. Are we okay with this idea? Great. So once I find my height, now I need to center side to side, right? I need to center to the MSP. Now, if I start to float my table again, watch what happens. Right, so it doesn't only go side to side, right? It goes up and down as well. Suddenly, I don't remember where my center is, right? I don't remember where my iliac crest is anymore. Except I do, because I made sure to put my finger where my centering was earlier. So, once you find your iliac crest, right, when you start to float your table around, make sure you mark the height of the iliac crest. In fact, better yet, mark the actual center where you were, so you know how much further you need to go left or right. For example, I'm going to say I need to go in about 2 inches here, right? I'm about 2 inches away from the MSP. I'm going to put my finger right here. So I'm going to touch your stomach. I'm going to put the finger right here. And when I start to float this, right, I'm going to be moving this in relation to my finger. Right, that looks about the distance I mentioned earlier, right? So I'm going to lock it there, and let's take a look. All right, wow, that looks really, really close. Maybe I think I need to come one way or the other slightly, right? Put my finger here again, so that I can make just a small change, right? I can just make a small change, and I know exactly how far I am going. Does that make sense? All right, great. So, make sure you mark your centering when you are about to float your table. So now I am at iliac crest, and I am at the MSP. Good so far? Okay, if we take a look at our patient, female reproductive organs, right here. Can we shield?
Yep.
No.
Oh, yeah.
No.
No.
No, right? We're trying to
No.
shield reproductive organs, but they are right in the middle of what we want to look at. So there is no way for us to shield female reproductive organs. Male reproductive organs, where are those located? Right, male reproductive organs would be right here. Notice that's just outside the light. So if you really, really wanted to be a good tech, you could attempt to shield male patients for the abdomen. You just come over here like this, kind of pop the very corner of your shield in here, so it's where the pubic symphysis would be, and you shield the male reproductive organs right here. Okay. Once again, you do need to be confident that when you do this, you are not going to cover the anatomy of interest. If you suspect that you're going to cover anatomy of interest, then just don't do this at all. Okay? But if you think you can get away with it and you can shield the patient's gonads, then please, by all means, try it out. All right? But once again, male patients only, because their gonads are more inferior. Okay. If we take a look here, right? This is lengthwise. Collimation line is to the very edge of our patient, so that's great. Up and down, we're right here to the pubic symphysis. We can't collimate anymore. We need a pubic symphysis. Up here at the top, does it look like we will catch diaphragm?
Looks like a little low.
It's kind of iffy, right? Diaphragm is going to probably like end up here because when we breathe out, it's going to be at T8. Right? It's going to be up here closer to the axilla. So we're probably not going to get diaphragm on this one shot. If we do not get so do I need to center higher to get the diaphragm? Why not?
This area.
Right. Right now, my main concern is to catch pubic symphysis. If I miss the diaphragm, that's okay. I'll just do a second picture later for the upper abdomen. But right now, when I center at the iliac crest, my concern is to catch the pubic symphysis. If I don't get the pubic symphysis, there's no point to doing this image. All right. I've got two markers here, left and right. Which marker do you want to use?
Use your right one because it's closest.
So you could use either one, but right side is closer to me, so I'm just going to use the right marker. All right, I'm going to pat the patient here on the side, and there is no light here on the table. So I've got nowhere to put my marker. Do I still use it?
Yes.
Okay, yes. I do still want to use my marker, even if there's no visible light. So where should I put this marker?
Up here to the right,
Right lung.
right there.
So do I want to put it up here?
No.
Is this lung?
No.
No, this is not lung anymore. What is this?
Probably
That's lower.
Ga-
So.
gallbladder.
Right, this is like liver or
Oh, yeah.
gallbladder, right? This is still abdomen. So where do I want to put this marker then?
I guess toward the bottom, maybe toward the pelvic, because it's not a pelvic exam.
All right, so if I have my marker here, what anatomy is right here? What is this?
Faces, sacrum, crest.
Right, that's the hip. Right, hip is not the hip is not the abdomen. This is the bony hip right here. So, yes, we can place the marker down low by the hip so that it's not in our abdominal anatomy. Now, can you put the marker on top of the patient like this?
No.
So yes, you could leave it here on top of the patient. But there's a couple problems with leaving it on top of the patient. One, you notice that my marker is starting to lean, right? So it's going to look crooked or slanted or smushed when we take this x-ray. Two, because it's so high up, it's going to look magnified. And three, if I forget about my marker, and the patient gets up and walks off and goes home, well, that's still going to be stuck on them. Or it's going to be in the blue bag because they threw away their gown. Right? And then I have to go digging for my marker. So, ideally, rather than putting it here, you would slide it underneath the patient, right? So you just turn a little bit to your left, right? Turn back. Okay.
Ah.
Right. Underneath the patient. So now it's going to be in the corner. It's not on top of them. It's nice and small. It's not going to be crooked, and it's less likely to walk off of them. Can it still walk off? Yeah, it could, but less likely. Okay, so we've done our centering, our positioning, our collimation, our marker. We considered shielding, decided we can't do it on a female patient. Now what? Breathing instructions, great. So Veronica, take a deep breath in, please. Blow it all the way out, all the way out. Good. Hold it out. Don't breathe. X-ray. You can breathe. You can relax. Very good. And that is your AP supine abdomen. Remember, the erect abdomen and the supine abdomen are your two mandatories. Those are the two that you must do for meeting this test. Okay, any questions? Good so far? Great. So of course, once I finish the exam, I'm going to make sure to put things back in a way that makes it easy for the patient to get off the table. All right. Okay. Out of the way so she won't hit her head. Okay. The marker did not lock off with her. Okay. So, who would like to be the next volunteer? Shamika, okay. By the way, how is the table, Veronica?
I was starting to get a little sleepy with the moving around.
Oh, okay.
Like rocking.
Ah, so it's comfortable enough.
Yes.
Very nice. Okay, so Shamika, you would have a seat here. Okay. So next up is going to be the PA probe. Now, with this one here, there's two ways you can approach it. Number one is you can put your patient prone from the very beginning and then do all your setup. But personally, I prefer to have my patient supine at first, raise my table, and then flip them prone. And the reason is that I believe that supine is a bit more comfortable than the prone is. And I want my patient to be comfortable for as long as possible. So Shamika, go ahead and lay down on her back and over here by this pillow. Face up. Very good. Now, as I say, a lot of different words to remind the patient that they should be facing up, because patients have a bad habit of not quite paying attention all the time, and they will lay down in the most random positions. So, now that the table's up, I'm going to have her flip probe. So, make a slide towards me first. Whole body, go. Then I'm going to return, so now you face down. Just bring your hands up above your head like this. All right, great. All right, so I've got a pillow here for her to rest her head on. Arms are up out of the way. I have the table up. What is the first thing I should do? What is the first thing I should do?
Find your center. Lock it.
Don't need to lock my table. And I do not want to find my centering. What do I want to do before I find my center?
Line up with the bucky.
Is it the bucky?
No, I'm sorry, you did that
All right,
already?
sure, I'm already lined up.
Okay.
But, what did Shamika just say?
Make sure I'm straight.
Oh,
Make sure
oh,
she's
yeah, yeah.
straight. Good. How do we do that? Great.
Oh, no, no.
What do you think? What do you think, Cindy? Is she straight? Oh, don't touch that. Okay, so
Yes.
thank you for doing that. One more thing. My biggest pet peeve, right? My number one pet peeve is in lab or in clinic overall is techs coming over and touching shoes, especially touching the bottom of shoes. And then guess what they do after touching the bottom of the shoe? All right, let me palpate you, okay? Let me palpate you. Let me just put my gloves that were all over the bottom of your hospital-covered shoes onto your body, right? Let me just spread all of that stuff onto you. No, do not do that. Okay, so avoid touching shoes as much as possible. If you need to be down here, you can grab the ankles, right? No problem grabbing the ankles. But don't grab the bottom of the shoes, or shoes in general. But yes, we do want to center our patient. So we're going to stand here, take a look. All right, maybe she can move her hips. Actually, she actually looks really straight.
Yeah.
I think, okay. Yeah, so she doesn't need to move at all. She's great. Okay. Right now, not a big deal, but especially next semester in the fall, when you start doing lower extremities, be very careful with the shoes. Okay, so now that she's straight, we can look for our centering. Okay, PA centering I actually think is a bit easier compared to AP because there's no as's in the way to confuse you. Right, so you're just going to come over here and you're going to just come straight to the side and look for that iliac crest. So excuse me, pardon me. Oh, I feel something. Sorry, Shamika. A bit of pressure. Okay. So I do believe the iliac crest is right here. Okay, so I pushed in, I felt resistance, I felt what felt like bony structure, moved up, felt more resistance, moved up, didn't feel any resistance, right? So at that point, I believe that I'm in the muscle right above the iliac crest. So I'm going to go ahead and get this nice and centered. Okay. I'm going to pat down her clothes to make sure I can see the sides of her clearly. And I do think that I'm really close to MSP. Okay, once again, just like with the chest, I can try and find my MSP by following the spine all the way down. So, looks like I am MSP. Of the spine, right, follow all the way down. Right, MSP. Okay. Right. Once again, I want to be a good tech. I want to make my patient comfortable. All right, so bring her legs a bit closer together. Good. Back down. Yep, back down. Great. Pillow here underneath the legs, underneath the ankles. All right, so now what? Marker. Great. Marker and collimation. So if you take a look here, does it look like I cover the entire abdomen? Okay. Chances are probably not, right? I have a lot of shadow on both sides of my patient. So for lab demonstration, right, I'm going to act like this is going to be my centering. But I will show you later what I would do in a real life scenario. Okay, which marker do I want to use?
Left.
Great, left side's closer to me. I'm just going to go ahead and use my left marker. And where do I put this left marker?
Are you missing it underneath the patient?
Great, bottom corner, preferably underneath the patient. Right, so just gonna have to turn a little bit away from us. Sneak it somewhere down here. All right, turn back. All right, and here's our marker. Okay, so centering, positioning, collimation, marker, considered shielding, can't because it's a female patient. And now we can do our breathing instructions, right? Okay, so Veronica, if you would please.
Make breathe in, hold it, X-ray, breathe in. Oh no, it's breathe in, breathe out.
Good.
Okay, breathe in, breathe out, hold it, X-ray, and then relax.
Very good. So breathe in, breathe out, hold it, X-ray, and relax. Great job. Okay, so that is our PA Pro. Right? If you can't do an AP, you are allowed to do your abdomen's PA. It's just this image will not be as good. Why? Because your kidneys are going to be super magnified. Right? On the chest, why don't we like to do a right lateral, or why don't we like doing AP? Because the heart looks magnified, right? In the case of the abdomen, now it's about the kidneys. The kidneys look magnified on the PA. They look much better on the AP. So PAs are possible, but APs look nicer. Now, let's say Shamika was a real patient. Okay? And you notice that you aren't going to cover the entire patient on your X-ray. What can we do?
Do the crosswise.
All right, great. What if we did her crosswise instead?
I think.
All right, does that cover the entire abdomen?
No.
No, we still have some out here that's not quite covered, right? Now the light is a little bit tricky. Just because it doesn't fully cover the abdomen doesn't mean that it won't be on the image, because the X-ray beam does diverge. But still, this is kind of iffy, right? It's not quite certain whether or not we're going to get the whole abdomen on here, or at least left to right. So in the case of patients like this, you may need to do quadrants. Right? So you may need to do 4 pictures instead of 2. Instead of just upper and lower abdomen, you might need to do upper left, upper right, lower right. Does that make sense? So in this case, right, just as a demonstration, so I'm still here at MSP, but now, sorry, I'm still here at the iliac crest. Okay, but now MSP is right here. Okay, I am leaving my collimation open just a bit beyond the MSP, right? This is my MSP. My collimation is open just a bit past the MSP. Over here, you see that we have a little bit of light now, right? See a little bit of light here, correct?
Yes.
So turn away from me just a tiny bit. Right, thank you. Back down. So now I can actually take my marker and put it inside the light. Right? Don't need to worry about it inside the anatomy anymore. So I do one X-ray like this. This is going to be left lower. Then, keeping my iliac crest, I'm going to jump across to the other side. And then I do right lower.
So your collimation will stay on MSP, basically?
So my collimation is going to just slightly cross MSP. That way, I have overlap. If I can see the same structure here in the middle on both images, that means I have covered the whole abdomen.
Okay.
If I can show overlap, it proves I've covered everything from left to right. Okay, and after we do this, right, we then just slide up this way to make sure to get the diaphragm, and we do, right, 1 and then 2, just like that. So we end up doing 4 pictures, quadrants.
And just offhand, how do we know how much you're moving it up? Is it just How did you just,
Okay, so for upper abdomen, right?
yeah,
You can try doing your 2 inches above the iliac crest,
okay.
or if you were a tech, right? If you were a tech and you did not care about trying to measure things out, because that's what techs are like. So they're not like students; they don't like measuring out 2 inches for whatever reason. What you would do is, okay, Shamika, take this left arm and bring it down by your side. Perfect. Very good. Axilla, correct?
Oh, perfect, okay.
Top of the light to the axilla, and you're almost guaranteed to have your diaphragm right here.
Okay.
So, upper abdomen, you're aiming at the axilla. Lower abdomen, you're aiming at the pubic symphysis. Make sense?
Mhm.
All right, very good. You okay there, Shamika? All right. Movement and we'll get you off.
See, looks like Mika fell asleep up there.
Yeah.
All right, you can stand up. Need help? Okay. And so that is our prone abdomen, we have a PA prone abdomen. Another sheet, please. Oh, mhm. Any questions so far?
No.
Now, you can also do PA erects as well, right? Same idea. If you can't go AP, right, you can always do it PA. Just be aware that the kidneys are going to look terrible on a PA. One more bonus thing about doing a PA, so something that might be worth considering if you do not care about the kidneys at all. If you know for a fact you don't care about the kidneys, you can do these PA to reduce dose to the gonads. Because if you think about it, the reproductive organs are all anterior, right? Male reproductive organs are in the front, female reproductive organs are also towards the front of the abdomen. You do a PA, you're putting a layer of tissue in between the X-rays and the reproductive organs. So they will receive less dose. But once again, kidneys will look terrible in the image. So only do that if you know for a fact the doctor does not care about the kidneys. Usually they care, so by default we do an AP. Okay? Great. Who is going to be our next volunteer? All right. That's right. We only have one person left. Okay, so have a seat, please. We're going to be laying down over here on our back, face up. Okay. So, the next projection we have to cover is the lateral abdomen. Now, lateral abdomens are not common. Right? For the test, you always do PA lateral. Right? But for abdomen, you almost never do the lateral. It's almost always just going to be your AP supine and maybe an AP erect. Okay? But in the rare case you do get a lateral abdomen, let's talk about how we do that. So, first things first, we are raising this table up to our height, correct? Next up, patient, slide towards me. Yes, or just slide. Great, and now go towards your left, so that we face that wall. So notice how I had her slide towards me first, right? That way it gave her room to roll onto her side. And then when she rolls onto her side, we're gonna ask her to slide backwards even more. Backwards. All right. Oh, sorry, Veronica, could you pass me that pillow behind here? Great. Just like all the times we have them laying lateral on the table, we take the pillow, put it here between the knees. So, how does this look? Are we in a good lateral position?
No,
What's wrong?
she's still crooked.
She's crooked. Right, so we come here to the end of the table, and we
crooked.
take a look at this and we say, all right, how can I fix this? Well, in this case, what we're going to do is we're going to try and take these hips and move them forward. So can you bring your left hip forward? Yep, good. All right, how does that look now? Are we still crooked?
Maybe the top portion we still.
All right, so stay right there, Shamika.
Okay.
You're going to be my guide, so I'm going to bring your shoulders back so that you're in a true lateral. This hip slightly forwards. Good.
Now that looks
True
better.
lateral. So, MCP, right? MCP looks like it's going to be above here. Is that straight? Is this MCP straight, or is one side more forwards, one side more backwards?
This side looks more. Yeah, just a little crooked, just
Still
slanted a little bit.
Right, I think the shoulders are forwards a little bit too much here. Okay, so, try not to move. I'm just going to grab the sheet here and slide it back a tiny bit, okay? Alright, how about now?
Yeah, that looks better.
That's better? Okay. I'm going to come over here to the head, just to double check. Yep,
That looks better.
that's much better now. So, right, always go to the ends of the table. Make sure your patient is straight before you do anything else. Okay. So now it is time for me to center. Where do I find my centering? Is it going to be iliac crest or 2 inches above?
2 inches above.
It's 2 inches. 2 inches above.
2 inches above. Remember,
Only this way.
as long as it's not AP supine or PA prone, 2 inches above. So, lateral, also easy to find the iliac crest. Why? Because it's right here for you. It's right here on the top now. So, all right, great. Iliac crest, right here. Okay. I can cup the crest, right here. Okay. You can feel it curve like this, up and then back down. So this topmost part, right? This is my crest. You feel down here, you feel bone, you feel up here, it's only soft tissue. From here, 2 inches out, right? So 3 fingers, and I'm going to be going right here. Careful, Shamika. Just going to slide towards you. So this is my height. This is how far I want to go this way. Right? So now I just need to figure out front to back. So I want to put this MCP. Honestly, I think we're about MCP right now. Okay. Straight down the middle, MCP. Patient is in true lateral. Just to shoulder flex a tiny bit. Forwards a tiny bit. Good. Okay, since I wrote her, I'm going to adjust. And now, markers. Which marker am I going to use?
The side that's up.
Side that's up,
No, the side that's down.
side that's down.
No, side up.
I
Side
don't
up.
know.
When you did your lateral chest x-rays, which marker did you use?
Left, right, back.
The side that's up.
Left.
Touching the-
Side touching the IR, right?
Mhm.
Where's the IR?
And above you.
Underneath. Which side is touching the IR?
The left.
The left.
Left side. So which marker am I using?
The left.
Left. Very good. So I need a place to put this left marker. If I had a so just kind of come around. If I can find some light in front, I will just sneak it somewhere down here, right? Or maybe somewhere up here. Right? Up here is chest, so maybe here, but of course, kind of dangerous to slide it in like this. So just be careful. Maybe I'll slide it under the sheet instead so that there's no misunderstandings. Okay. So yeah, just take the marker. Put it somewhere here. Just let the patient know what you're doing. Okay. So, we have centering, positioning, collimation. Can't really collimate too much, right? Just leave it to its full size. Marker, we considered shielding. Patient's female, can't shield. So now what?
Breathing.
Breathing, great. So, Sindhu, can you give us the breathing instructions, please?
Samantha, take a deep breath and breathe out, hold it, and exhale, and relax.
Okay, very good. Breathe out, hold it, X-ray and relax. Great. Any questions about the lateral?
Still 14 by 7.
14 by 17 lengthwise. Let me slide this below off to my resistance. Okay, one more thing that you may notice that I do, I can't remember if I told you previously during chest, but I don't actually tell the patient when we're done. I don't tell the patient when we're done because they do exactly that. I say we're done, they try and jump off the bed immediately. Right? So I take time to set things up to where they can get off, right, while still talking to them, keeping them kind of distracted. So once we're actually ready, it's like, all right, now you can get up. All right, very good.
Alrighty, guys. 4 positions down.
5.
Oh,
4 positions down. That's
Actually,
right.
4.
Okay.
So 2 more positions now. Okay.
what
We're not
is it?
supposed to do this in clinic.
Yeah.
Small, so we'll just. It's like interviews.
That's like the nursing
Okay.
home.
I don't actually do this to patients, right?
I know, just teaching it.
So, our final 2 projections are going to be decubitus positions. So, is anyone willing to help me out with the decubes? Okay. Oh, then. So, first of all, as with all decubes, we are going to need to build the patient up. Okay, so you're going to have the pillow, and you're going to have your sheets here in the middle of the table. Second, we need our cassette holder. Yep, so the music stand is in the back, and I've got my 14 by 17 right here. Okay, now, I did not tell you guys this on the chest section because I didn't want to confuse you. At least I don't think I told you. But the cassette actually has a certain orientation. Here itself, green strip needs to go towards the head. Okay.
Yeah, you did mention,
A little bit, yeah.
student from Mexico having a fill-in.
Oh, I did. Okay, great. I wasn't sure if I told that story or not.
What was that lab at school?
Mhm.
Okay. So Veronica, were you our volunteer? Okay.
Yeah.
Go ahead, lay down on top of these sheets, right over here by the front.
Right side down.
Nope, just face up, face up. Alright. Very good. Because this is a decubitus, this tube is going to be somewhere out here, right? Because we're doing a horizontal view.
We got dorsal, one ventral.
All right, patient. Moving up. Moving up now. So even though this is a decube, right, my order of steps does not change. First thing I do, bring the patient up to a height where it is comfortable. Second thing, from here to the head of the foot, make sure the patient is properly lined up. Make sure that you're nice and straight. Once that is done, now I can worry about everything else. So, let's move this tube over here. Okay. When we did the chest decube, what is the SID?
72.
72, or as close as possible, right? Abdomen, what did I say the SID is?
40.
40. So you are no longer going to be going as far as possible. You are actually going to measure out a 40-inch SID. So we need this image receptor to measure out SID. I'm going to take this and put it right next. I'm going to put it right next to our patient. All right, let's see. Okay, can you scoot your hips towards your right, just like not your shoulders, just the hips. Perfect. All right. So image receptor nice and close to the abdomen, nice and close to the patient. Minimum OID without causing the patient to be crooked. If you look here, the tape measure is down here, right? So let's say that I'm centered to my patient's MCP, and I pull out this tape measure like this, and like, and I'm like, all right, 40 inches. What's wrong?
It's like slanted.
Exactly, this is slanted, right? This is not an accurate distance. In order to get an accurate distance, I need to be able to put a tape measure straight across. And this is actually 36. So this is 40 inches right now. Okay, so you get your SID here first. Once you get your SID, you never touch the gray or the blue buttons ever again. You never float the table ever again. Does that make sense? Because you've gotten your distance. Anything you do to change that distance will force you to start over. So don't float the table, don't float the tube, don't touch the blue button. Only green and yellow from now on. That is all you need. So, speaking of which, let's get our centering. What kind of decubitus is this?
Dorsal?
Left, lateral.
Oh.
Yes, this is a dorsal left lateral decubitus. Underneath. Keep going. Underneath. There you go. Back down. This is a dorsal because patient is on your back. Left lateral because left side is against the IR. Decubitus. Or left lateral dorsal decubitus, right? Left lateral dorsal decubitus. Say that 5 times fast. So, where's my centering for the dorsal DQ?
2 inches above.
Right, 2 inches above. So I'm going to come here to the side. Let's see if I can find that earlier crest. I think I have it here. Okay, so there's my iliac crest. 2 inches, right? So my 3 fingers. So I'm going to be aiming right about here. Oops, sorry. I'm going to be aiming right about here. So, remember, I'm not touching the blue, only the green. And of course, I don't think I mentioned it earlier, but do make sure you switch this over to tabletop for cassette. Collimation all the way open. So 2 inches above the iliac crest, slide this up as well. Point your belly button for me, please. Great, back down. Yep, very good. Okay, so we got our height, now we need to get our MCP. All right, so bring your hands up here by your head. Just nice and relaxed. Take this, bring it down, MCP, right here, front of the armpit, front of the axilla. From here, follow me. Just make sure that you don't have light on your IR. Follow me. Don't need breast tissue, right? We're just collimating to the abdomen here. And then, marker. So, left marker or right marker? Left marker? Why?
It's just closer to the IR.
Left side is touching the IR. Very good. So we do use our left marker. Right side up or sideways, for me, doesn't matter. I like to put it sideways to follow the patient. My marker has the beads in it, so they will show where gravity falls. Okay. So we did our centering, our positioning, our collimation, our marker. We considered shielding. Female patient can't really shield. So now what? Breathing instructions. Great. Shamika, if you would, please.
Okay, Veronica, I'm gonna give you breathing instructions. Take a deep breath in, let it out all the way, let it out, hold your breath. X-ray, breathe.
Great. Very good. So breathe out, breathe in, breathe out, hold it out, X-ray breathe. Okay. So any questions about our dorsal decubitus? Pretty straightforward. Okay, just notice that main differences from a chest. Patient is actually in the middle of the table. They're not all the way to the side, right? I don't need to be back here holding the cassette because it's all in the middle of the table now. And much smaller SID. Okay. Still don't move. You can sit up and stand. so who would like to help out for the final? EQ. So same thing, lay on your back, please.
No, he just pulls it out and puts it on that way.
Is that a good O or a bad O?
It's okay.
It's okay O. Alright.
It's getting older.
Getting old. I understand that feeling.
No, like everybody says that in class recently, and I don't know, I guess, like, I mean, because we have a lot of people in our 30s, you know, and it just, I don't know, a lot of people are saying, like, oh, you know, I feel so much older. Like, do you guys really? Like, is it that much of a difference from a decade ago? Like, I don't know.
Maybe it's that as long as it's a younger part.
I don't
As
know.
long as you feel like, as long as you don't think you're older, you're not. Alright, so this time, instead of a dorsal decubitus, we will be doing an actual lateral decubitus. So, in this case, the way it's set up, we are going to do an AP lateral decubitus. And because it's AP, that means it will have to be a right lateral DQ. But keep in mind, when you do this for real, which side you choose will depend on what you are looking for. More often than not, you are actually going to do a left lateral DQ. That is the most common one. So we're going to demonstrate right lateral DQ, but in real life, you're more likely to do the left lateral DQ. Okay. So, Cindy, if I could have you turn to face me. Great. Scoot back, make sure you stay on those sheets. Great. Good job. Actually, scoot down a little bit so that your body's more on the sheet. Alright. So, just like with the chest, I'm going to take a board, put it back here. Alright, scoot back a little bit. Yep, keep scooting back until you feel that board. Great, same thing for your shoulders. Good. Alright, so we've got our patient in this nice right lateral decubitus, correct? Hello, I'm going to go here between the legs. Thank you. Right shoulder back just a tiny bit more. Good. There we go. All right, nice and straight. So, looks familiar, right? All right, in this case, you don't need your arm all the way up now. You can leave it bent like that. Because this elbow is going to be in the chest area. It will not show up in the abdomen. Once again, just like before, first thing I'm going to do is I'm going to measure out my SID. Go ahead and bring this arm up as well. All right, so what is that? 40 something? 44 and a half? 41? 40, all right. Whew, getting kind of close here. Right? Be careful. Make sure you use common sense. If you notice that you're getting too close, you just bring your patient forwards instead. It's no big deal. But try and remain at a 40 inch SID. Okay, so from here, we are going to get our centering first. What is our centering in this position? Great, 2 inches above the iliac crest. So, I'm going to feel for the iliac crest right here. Okay, found it. 2 inches above. Should be right about here.
Right on,
Oh, I think I'm there.
right on spot, yeah.
Oh, no, this one. Oh. All right, in which case, I'm going to use this, slide it over as well. Okay. Nice and centered. All right, if we bring this arm down assembly, all the way down. Seems kind of high. Yeah, let's
Can we lower the line or something?
Maybe I'll just try and fit this way. Yeah, those are both sides. So in this case, you can see that the light is actually slightly above the axilla here. So this might be, we're definitely going to be getting lung in this case. In fact, I might even consider collimating, right, so that I don't get as much lung. All right, great. Arm back up. Put your elbow. Great. Perfect. Okay. Right, but make sure that our collimation is here within the IR. Right, collimate this way as well. I do want to make sure I'm MSP. So I'm going to take this, drop this down to make sure I catch my MSP. Honestly, it doesn't look as good this time because I think I put these sheets too far down towards her hips. They should be up closer towards her chest. And so that's something that I would want to correct next time I do this. Right. I do have a little bit of light here, right? So if I want to put my marker, this is a great spot to slide in that marker. So which marker am I going to use?
Upside.
Upside, which is? Left. Very good. All right, look good? Great. In which case, breathing instructions, right? Because we did our centering, we did our positioning, collimation, marker. We considered shielding, didn't shield. So, Samantha, if you could show us the breathing instructions, please.
Sure. Okay, Sindhu, I'm going to have you breathe in, breathe out, take another deep breath in, breathe out, and hold, and expose.
And then?
Oh, I'm sorry.
And then, after you expose?
Oh, you could breathe in. You can breathe in. You
Great.
can start relax.
Awesome, thank you. So, remember, if you start your breathing instructions, unless you accidentally autopilot onto your chest breathing instructions, right? Take a deep breath in, blow it all the way out, take another deep breath, oh no. I'm supposed to be doing abdomen breathing instructions. Take a deep breath in, blow it all the way out. X-ray, right? Doesn't matter how many times they do it, as long as you end on an expiration, you'll be fine. So 2 breaths in, 2 breaths out, no problem. As long as you make sure to end on the expiration. All right, so any questions about the lateral decubitus? Very similar to your chest lateral decubitus. Main differences are your centering, right? 2 inches above the iliac crest instead of T7, and your SID, 40 inches instead of 70.